a routine cancer screening, but your medical team is secretly worried you might literally combust on the operating table.
Right, an actual physical explosion.
Yeah, inside your body.
It's wild.
It is wild. Welcome to the deep dive. Today, we are looking at the explosive, highly chemical, and let's be honest, often dreaded reality of colonoscopy prep.
Oh, definitely dreaded.
For sure. So we have a stack of incredibly detailed clinical guidelines here, outlining the pharmacology, the peri-procedural medication management, and the whole patient strategy behind this process.
And it is a complex process.
It really is.
Yeah.
And our mission for you today is to take a medical prerequisite that is notorious for being universally despised and transform it into this fascinating journey through gastrointestinal pharmacology.
Because it really is fascinating.
Right. We want to show you exactly how your body, your daily medications, and your diet are manipulated in real time. Because, while drinking liters of salty liquid feels like a miserable chore.
A very miserable chore.
Yeah, the underlying science of how these chemical solutions force a complete systemic flush without crashing your entire internal ecosystem is, well, it's an absolute masterpiece of fluid dynamics.
The word masterpiece is actually entirely appropriate here. I mean, we are deliberately inducing a massive physiological event.
Right.
The medical team is choreographing this controlled high-speed evacuation of the entire gastrointestinal tract. And they have to do it while tiptoeing around the patient's existing heart conditions, kidney function, and blood chemistry.
It's like a high wire act.
Exactly. Because the colon must be pristine. Otherwise, the diagnostic imaging is compromised and the whole cancer screening fails.
And the procedures themselves kind of dictate how extreme that chemical flush needs to be. Because I always assumed that a colonoscopy was a uniform experience, but the clinical guidelines draw a sharp line between a traditional long colonoscopy and a virtual one.
They do, yeah.
And the type of procedure you get fundamentally alters the risk profile.
Right, so the traditional long colonoscopy involves a gastroenterologist actually navigating a scope from the rectum all the way up to the ileum.
So they're going all the way in.
All the way. They're physically inside that tissue landscape. And if they spot an adenoma, which is a precancerous polyp, they'll likely perform a polypectomy right on the spot.
They just cut it out then and there.
Exactly, using an electrical snare. But because they are slicing tissue, the patient faces a significant risk of severe bleeding.
Oh, wow. Okay.
Now, a virtual colonoscopy, on the other hand, relies entirely on radiologic imaging.
Like a CT scan.
Right. The patient drinks a contrast dye, and a scanner captures a 3D rendering of the colon. So there are no scopes, no cutting, and therefore zero risk of procedure-induced bleeding.
But both procedures still demand the exact same grueling bowel prep. I mean, if I'm just getting a scan, swallowing a harsh chemical laxative feels like overkill. The scanner should just be able to, look past whatever's in there, right?
You would think so. But a radiologic scan cannot differentiate between a lingering piece of stool attached to the colon wall and a potentially lethal polyp.
Wait, really? They look the same.
Their densities and shapes can mimic each other perfectly on the imaging.
Oh, that's terrible.
Yeah, so if the bowel isn't immaculate, the scan produces a false positive. And then the patient ends up needing the traditional colonoscopy anyway just to verify.
So you have to do the prep twice.
Exactly.
However,
the lack of bleeding risk with the virtual scan completely changes the entire medication strategy. If we connect this to the bigger picture, think about a patient with severe atrial fibrillation or maybe a mechanical heart valve.
right, so they'd be on heavy medications.
Aggressive anticoagulants, blood thinners to prevent a catastrophic stroke. For a traditional colonoscopy, taking them off those blood thinners so they don't bleed out during a polypectomy.
Puts them at immediate risk for a clot.
Exactly. But the virtual colonoscopy allows us to screen that high-risk patient for cancer without exposing them to either surgical bleeding or a stroke. We only take them off their life-saving medication if the scan definitively proves there is a polyp that absolutely must be removed surgically.
Okay, let's unpack the timing of achieving that pristine colon. The clinical standard mandates what's called a split dose regimen. You drink half the chemical prep the day before and the other half the morning of the procedure.
Right, the split dose.
It just seems like a cruel scheduling tactic to wake someone up at 3 a.m. to drink salty laxatives. I mean, I'd much rather just drink the entire jug at 8 p.m., power through the bathroom visits, and sleep until my appointment.
So if you did that, you would arrive at the clinic with a contaminated colon.
But I flushed it all out.
You did, but it comes down to the mechanics of gastric emptying and this substance called chyme.
Chyme.
Chyme, C-H-Y-M-E. It's the semi-fluid mass of partly digested food and secretions that just constantly resides in your small intestine.
Oh, gross. Okay.
So if you take the full dose of the prep the evening before, yes, your large intestine will be perfectly clear by the time you go to sleep. But human digestion doesn't stop.
It keeps going.
Right. Throughout the night, the chyme from your small intestine continues its slow, steady migration downward. It leaks through the ileocecal valve and enters the proximal side of the colon.
Okay, so it's basically like trying to mop your kitchen floor to perfection, but you're ignoring a leaky ceiling directly above it.
That's a great way to look at it.
Like, you go to bed with a spotless floor, but the ceiling drips dirty water all night. By the time the doctor comes in to inspect the kitchen in the morning, the right side of the floor is just covered in a murky film.
That is exactly the mechanism at play. That morning leakage coats the mucosal walls and drastically lowers the adenoma detection rate.
Wow.
So the morning half of the split dose, that acts as a final high-pressure rinse, washing away that accumulated chyme just hours before the camera goes in.
And that timing only works if the liquid itself is chemically powerful enough to force a complete flush in just a matter of hours. Which brings us to the pharmacology section of these guidelines. And honestly, it reads like a mad scientist's inventory.
It really does.
The undisputed gold standard is PEG-E+, which stands for polyethylene glycol with electrolytes. My initial assumption was that the E+ part was like a sports drink. You know, you're losing a ton of fluid, so the solution is packed with electrolytes to replenish what you're sweating or flushing out.
Yeah, that's a very common misconception. But it's actually about creating a strict chemical stalemate.
Stalemate.
Right. Polyethylene glycol, the PEG, is a massive synthetic polymer. Its molecular weight is so large that the human body physically cannot absorb it through the intestinal walls.
Okay, so it's just stuck in the pipe.
Stuck in the pipe.
Yeah.
And as this giant molecule travels through your gut, its chemical structure forms tight hydrogen bonds with water molecules. It acts like a microscopic sponge that just refuses to let go of the water you drank with it.
So it doesn't even stimulate the colon muscles to contract. It just uses osmotic pressure to drag a heavy, wet blanket of fluid through the pipes, sweeping everything out with it.
Precisely.
But why the E+ then? I mean, if the PEG is just holding onto the water I drank, where is the electrolyte loss coming from?
Well, if you drank 4 liters of pure water bonded to PEG, that massive volume of zero-sodium liquid rushing through your intestines would create a concentration gradient.
Because of osmosis.
Exactly. Osmosis dictates that fluids try to balance themselves out. So the pure water in your gut would rapidly pull sodium, potassium, and chloride out of your bloodstream and surrounding tissues to try and achieve equilibrium.
Oh, so it would suck the salt right out of my blood.
Yes, and the patient would suffer a massive, potentially fatal drop in serum electrolytes.
Okay, that's terrifying.
So the E+ means the solution is manufactured to perfectly match the exact electrolyte concentration of human plasma.
Ah, I see.
Because the liquid in the gut has the exact same sodium and potassium levels as the blood on the other side of the intestinal wall, there is no osmotic gradient. We call it an osmotic laxative. There is zero net transfer of ions or water into or out of the bloodstream.
That makes it incredibly safe for patients with fragile fluid dynamics, like someone with congestive heart failure. You aren't forcing excess water into their vascular system, which could overwhelm their heart, and you aren't dehydrating their tissues either.
Exactly. It's very safe.
But the trade-off is the sheer volume, right? 4 liters. And because it mimics human plasma, it tastes like thick, viscous ocean water.
It is not pleasant.
Which leads to the most obvious question. Why can't pharmaceutical companies just engineer this stuff to taste better? Like throw in some sugar, some artificial cherry flavor? I mean, we have the technology to mask the salt.
We do, but masking the salt with carbohydrates completely shatters that delicate isoosmotic stalemate we just built.
How so?
Sugars are highly osmotically active. If you load that 4-liter jug with sugar to make it taste like fruit punch, the solution suddenly becomes hyperosmotic. It will start aggressively pulling water out of the patient's bloodstream and into the gut, causing dangerous clinical dehydration.
Oh, wow. So you fix the taste but destroy the safety.
Right. But the second reason is much more visceral, and it ties back to that explosion risk we mentioned earlier.
The combustible gas.
Yes. When you introduce sugars or fermentable carbohydrates into the colon, the resident bacteria immediately begin digesting them. And the byproduct of that bacterial fermentation is hydrogen and methane gas.
Oh, no.
So if a doctor encounters a polyp and applies an electrical snare to burn it off, that tiny electrical spark occurs inside a chamber now filled with highly flammable methane.
And the patient literally explodes on the table. Okay, message received. I will happily endure the salty ocean water. Keep the sugar far, far away from my colon.
A wise choice.
But the guidelines do mention lower volume options. Some preps combine the PEG with a massive dose of vitamin C or ascorbic acid, dropping the requirement from 4 liters down to 2. I always thought vitamin C was just for immune support. How does it clean out a colon?
Well, the body's ability to absorb vitamin C actually has a strict ceiling. If you consume a massive pharmacological dose of ascorbic acid, the intestinal transport mechanisms are completely overwhelmed.
So the extra just sits there.
The unabsorbed vitamin C remains trapped in the gut. And because ascorbic acid is osmotically active, it acts as a secondary osmotic laxative, actively drawing more water into the colon. Combining PEG with ascorbic acid gives us a dual-action pole, meaning we only need 2 liters of fluid to achieve the same sweeping force.
Okay, a 2-liter requirement that tastes slightly tart instead of 4 liters of salt water sounds like a massive upgrade. Why isn't this just the default for everyone?
Because of a very specific genetic vulnerability known as G6PD deficiency.
What's that?
Glucose-6-phosphate dehydrogenase is an enzyme that protects red blood cells from oxidative stress. When ascorbic acid is administered in these massive, unabsorbed doses, it can temporarily act as a pro-oxidant in the gut.
Okay.
For a patient lacking the G6PD enzyme, that sudden spike in oxidative stress physically shatters their red blood cells. It triggers a massive cascade of hemolysis.
So their blood cells just burst.
Yes, we can cut the volume in half, but doing so could destroy a vulnerable patient's blood supply.
Man, the stakes are so high. Then we have PSMC, which is sodium picosulfate and magnesium citrate, and this is moving away from the gentle water retention of PEG entirely.
Right. PSMC is a chemical sledgehammer. It's a low-volume prep, but it forces the body to do the work.
How does it do that?
The sodium picosulfate directly stimulates the mucosal lining, forcing the colon muscles to violently contract and push. Meanwhile, the magnesium citrate acts as a hyperosmotic saline laxative, actively pulling fluid out of the body's tissues and into the gut to flush the system.
Which means it's causing severe rapid fluid shifts.
Very severe.
If a patient's kidneys are already struggling, suddenly forcing their body to dump fluid into the gut sounds incredibly dangerous.
It is entirely contraindicated for anyone with severe chronic kidney disease or heart failure, precisely because of those fluid shifts. And that danger actually brings us to the darkest corner of the pharmacology guidelines: sodium phosphate.
Yeah, the clinical notes specifically state that sodium phosphate is strongly advised against by the FDA and Canadian gastroenterology guidelines, even though it used to be a very popular ultra-low volume option in the past. So what happened?
We discovered it was causing irreversible acute kidney injury.
Oh my God.
Yeah. Sodium phosphate relies on delivering a massive concentrated load of phosphate to draw water into the gut. But some of that phosphate inevitably gets absorbed into the bloodstream.
And that's bad.
Very bad. When serum phosphate levels aggressively spike, it disrupts the body's entire endocrine feedback loop. The parathyroid gland reacts, and the excess phosphate rapidly binds with free-floating calcium in the blood.
So it essentially steals the calcium.
And those new calcium phosphate complexes are physically solid.
Wait, solid? Like stones?
Like crystals. They precipitate out of the blood and form jagged microscopic crystals inside the narrowest, most delicate filtration systems of the body, the proximal tubules of the kidneys.
Oh, that sounds agonizing.
Patients were waking up from their colonoscopies with permanently damaged renal function because we accidentally crystallized their kidney tubules.
That is horrific. And here's where it gets really interesting. That massive fluid shift from the gut doesn't just happen in isolation. It slams directly into the pharmacology of whatever else the patient swallowed that morning.
Yes, the daily medications.
Managing a patient's daily prescriptions around this chemical flush is like trying to drain a city's reservoir without losing water pressure to the power grid. You have to pause certain valves, but the moment you do, the pressure in the rest of the system collapses.
That's a perfect analogy. The clinical guidelines refer to this as the sick day rules. The bowel prep is essentially a medically induced bout of severe gastroenteritis.
Right, fake food poisoning, basically.
Exactly. The patient is experiencing controlled, high-volume diarrhea, placing them at significant risk for acute dehydration. To protect the kidneys during this dehydration window, medications that alter renal perfusion must be temporarily suspended.
So we are talking about ACE inhibitors and ARBs, the heavy hitter blood pressure medications, along with diuretics.
Correct. A diuretic forces the kidneys to excrete water. If a patient continues taking their diuretic, while simultaneously enduring an induced osmotic flush in their gut. Their kidneys are being drained from both ends.
They're just being wrung dry.
The renal system simply won't have enough blood flow to maintain basic filtration, leading to acute kidney injury. So we pause the diuretics so the body holds on to whatever water it has left.
But pausing those medications means their blood pressure is now uncontrolled, which is exactly why the reservoir analogy works. You save the kidneys, but you risk spiking the blood pressure.
Exactly.
And that delicate balancing act is nothing compared to the peri-procedural management of antithrombotics, the blood thinners.
Oh, the antithrombotic strategy is arguably the most complex clinical decision made before a colonoscopy.
I can imagine.
We return to the bleeding risk of the traditional colonoscopy. If a patient is on warfarin or a direct oral anticoagulant, and the gastroenterologist cuts out a polyp, the mucosal tissue will hemorrhage. The blood thinners prevent the body's natural clotting cascade from sealing the wound.
So the obvious answer is to just tell the patient to stop taking their blood thinners a week before the procedure, right? Let their blood return to a normal coagulating state.
But those thinners are prescribed for a reason. If we halt a patient's anticoagulants for a week, their underlying atrial fibrillation could easily cause blood to pool in the chambers of their heart, form a clot, travel up the carotid artery, and cause a massive ischemic stroke.
Man, you are genuinely weighing the statistical probability of the patient bleeding to death in the operating room against the statistical probability of them having a debilitating stroke in their living room 3 days prior. How does a pharmacist or physician navigate that?
They rely on algorithmic risk stratification, specifically something called the CHAIT-S2 score.
CHAIT-S2?
Yes, it calculates stroke risk based on congestive heart failure, hypertension, age, diabetes, and prior stroke history. If the mathematical risk of a stroke is deemed critically high, we use bridging therapy.
How does bridging therapy change the math?
It exploits the pharmacological half-lives of the drugs. A traditional oral thinner like warfarin has a very long half-life. It takes days to leave the system and days to build back up.
Right.
Bridging therapy involves stopping the warfarin days in advance, but replacing it immediately with a short-acting injectable anticoagulant like low molecular weight heparin.
Because the injectable has a rapid half-life, you can protect a patient from a stroke right up until a few hours before the scope.
Precisely. The heparin clears the system in a matter of hours, creating a tiny, tightly controlled window of vulnerability where the blood can clot just long enough for the doctor to cut out the polyp safely.
That is brilliant.
And once the procedure is over and the bleeding is controlled, we immediately restart the anticoagulants.
There is also a fascinating, highly specific rule regarding oral iron supplements. The guidelines mandate they must be stopped a full 7 days prior. Does iron interfere with the clotting cascade too?
No, the iron rule is purely mechanical. Human bodies are notoriously inefficient at absorbing oral iron supplements.
Okay.
The unabsorbed iron travels down into the colon, where it undergoes a chemical change that turns the stool incredibly sticky, thick, and pitch black.
Like tar?
It behaves exactly like industrial black paint, coating the mucosal walls. It completely absorbs the light from the endoscope's camera, making it impossible to identify the subtle contours of a precancerous adenoma, and the prep liquids cannot wash it away.
It's amazing how all this theory translates into a single patient's reality. And the clinical text provides this brilliant case study. It's a 55-year-old man who presents at a pharmacy with a prescription for Pico-Salax, which is that aggressive PSMC stimulant we discussed earlier.
The chemical sledgehammer, yes?
Yeah, right. And this man has a medical history of heart failure, atrial fibrillation, type 2 diabetes, and chronic kidney disease. He takes ramipril for blood pressure, rivaroxaban to thin his blood, and metformin for his diabetes.
This scenario is a pharmacist's ultimate stress test.
Seriously?
The medical secretary likely just printed out the clinic's default bowel prep prescription, entirely unaware of the catastrophic chain reaction it would cause.
Break down the pharmacist's interception here, because they immediately halt the PSMC prescription.
Right. What's fascinating here is the pharmacist looks at the patient's failing kidneys and compromised heart. PSMC, as we discussed, causes violent fluid and electrolyte shifts.
Which he can't handle.
Exactly. For this specific patient, forcing his body to suddenly dump massive amounts of fluid into his gut could push his heart failure into acute decompensation or even trigger a fatal arrhythmia. So the pharmacist overrides the clinic and switches him to the high-volume PEG-E plus PrEP.
The gold standard.
Yes, it requires drinking 4 liters, but the isoosmotic nature means his vascular fluid volume remains completely stable.
Then they have to manage the medication reservoir. The ramiprillin ACE inhibitor is paused under the sick day rules to preserve renal blood flow during the controlled dehydration of the prep. The rivaroxaban, the blood thinner, is paused based on its Shechet's 2 score to prevent hemorrhage during a potential polypectomy. But they also paused the metformin. Why is the diabetes medication caught in the crossfire?
Metformin is cleared from the body by the kidneys. During the bowel prep, the induced dehydration naturally slows down renal clearance.
So the kidneys are working slower.
Exactly. If the patient continues taking metformin, the drug isn't filtered out. It accumulates in the bloodstream. Toxic levels of metformin interfere with cellular respiration, leading to a life-threatening buildup of lactic acid in the blood, known as lactic acidosis.
Oh.
So the pharmacist pauses it to prevent the patient's blood from turning acidic while they are dehydrated.
The medical team is executing a flawless, high-stakes choreography of half-lives and osmotic pressures. But the patient at home is just trying to survive the physical reality of the prep day, The diet tweaks, the starvation, the endless bathroom trips. We really need to talk about the infamous clear liquid diet.
Yes, for 24 hours prior to the procedure, patients are historically restricted to consuming only transparent fluids, broth, black coffee, apple juice. And critically, a strict ban on any liquid dyed red or purple.
Because artificial red dye stains the mucosal lining and looks identical to fresh hemorrhage under the camera?
Exactly, causing the surgical team to panic over a bleed that doesn't actually exist.
But I noticed a massive contradiction in the guidelines. The clinical data heavily support something called the low-residue diet, or LRD. It allows patients to eat solid, low-fiber, low-calorie foods like white bread, chicken, eggs, right up to the day before the procedure. And the data proves it cleans the colon just as effectively as starving on clear liquids.
It is equally effective, drastically better tolerated by the patient, and clinically superior for populations like diabetics.
Oh, because of the food.
Right. When you force a diabetic patient onto a clear liquid diet, you remove all complex carbohydrates and proteins, leading to erratic, massive blood sugar swings and severe hypoglycemic episodes. The solid food of a low-residue diet stabilizes their glycemic index.
So if the solid food diet is proven to be just as clean, vastly more comfortable, and actively safer for diabetic patients, why on earth are hospitals still defaulting to the miserable clear liquid diet? The source specifically notes that while LRD is popular in the US and Europe, it is still met with heavy resistance in places like Quebec.
Well, this raises an important question about systemic healthcare logistics. Yeah. When a hospital issues a blanket protocol for tens of thousands of patients, they optimize for clinical foolproofness. The clear liquid diet is physically miserable, yes, but it has zero margin for interpretation. A liquid is either see-through or it isn't. The low-residue diet requires the patient to actively measure their macronutrients. They must keep their fiber intake strictly under 32 grams and their caloric intake under 2,000 calories.
Right. Someone assumes a massive bowl of whole wheat pasta is low residue because it's bland, they accidentally consume 60 grams of fiber, and the prep completely fails.
Exactly. If the patient misunderstands the dietary math, the colon remains obscured. The hospital wastes operating room time, the gastroenterologist's schedule is disrupted, and the patient has to endure the entire chemical flush all over again a month later. The clear liquid diet eliminates the variable of human error.
So to survive that foolproof torture, patients have developed a fascinating array of palatability hacks. Chilling the PEG Plus solution heavily dulls the temperature-dependent taste receptors on the tongue. Using a straw allows you to bypass the anterior taste buds entirely, delivering the salt water directly to the back of the throat.
And we also utilize highly targeted chemical hacks during the prep itself. The most elegant is simethicone.
What does that do?
When liters of liquid violently rush through the gastrointestinal tract, the fluid mixes with bile and mucosal secretions, whipping up a dense, opaque layer of foam. It looks like soap suds coating the colon,
which completely ruins the high-definition view the camera needs.
Simethicone is an inert defoaming agent. It doesn't absorb into the body. Instead, it physically alters the surface tension of those bile bubbles. It forces the tiny bubbles to coalesce into larger ones until the surface tension breaks and the foam entirely dissipates, leaving a crystal-clear visual field.
So what does this all mean? We started out looking at a medical chore that most people dread, but peeling back the layers reveals a truly astonishing scientific reality. The next time you find yourself staring down a 4-liter jug of Peggy Plus, you aren't just drinking a laxative. You are initiating a meticulously calculated osmotic stalemate. You are participating in a pharmacological balancing act that manipulates cellular hydration, manages stroke risks through biological half-lives, and relies on the surface tension physics of defoaming agents.
It is an invisible, heroic physiological effort, and it is the absolute foundation that makes early cancer detection possible.
But I want to leave you with a final thought based on that exact defoaming technology. The clinical text highlights our ability to use targeted drugs like simethicone to pop bubbles and prokinetics to selectively stimulate specific muscles in the upper colon. If we already possess the technology to chemically target specific physical anomalies in the gut without systemic absorption, how long until the liquid prep is obsolete entirely? Could the future of colonoscopies bypass the fluid dynamics altogether, replacing the 4-liter jug with a harmless, indigestible nanosponge or a microbot that physically sweeps the colon clean without forcing you to drink a single drop of salty water?
The trajectory of gastrointestinal pharmacology certainly points in that direction. We are always looking for more elegant ways to clear the diagnostic landscape without pushing the patient's biology to the absolute brink.
Until the nanosponges arrive, at least you now understand the breathtaking chemical choreography happening inside that plastic jug. Thank you for joining us on this deep dive. Stay curious, stay informed, and we'll see you next time.